Good day. I'm Dr. JB Alonto. So this is part two of the module in series of lectures in orthopedics. So as a review of a musculoskeletal system, we already discussed skeletal muscle, tendons, joints, ligaments, bursa, synovial sheath, bone, and cartilage in the previous lectures, and we'll be discussing bone healing in this lecture. Pretest for the lecture. So we'll be discussing fracture healing. So the components of fracture healing is basically it's a complex and dynamic process. So the essential components would be your cells, then you have your scaffold, your blood supply, and you have your molecules. So the cells in particular, we're concerned about the inflammatory cells, progenitor cells, the chondrocytes, the osteoblasts, the osteoclasts, the muscle cells, and their importance in fracture healing. By scaffold, we mean the hematoma, the collagen, the non-collagenous proteins that act and support bone healing. Blood supply will be dealing with the blood vessels and the supporting cells, and we'll be discussing the molecules that are also important in bone healing. Subsequent sections of this lecture will further describe the coordination of these components in the process of fracture healing and how it can affect bone healing. So by inflammatory cells, we mean platelets, neutrophils, macrophages, and leukocytes that are found in the fracture site within the first R. So platelets, basically, they release their growth factors, particularly your vascular endothelial growth factor, your transforming growth factor beta, your fibroblast growth factor, your insulin-like growth factor 1, and platelet-derived endothelial growth factors. Neutrophils, they perform both phagocytic and degranulation functions at the site of the trauma. And your macrophages and precursor monocytes, they act to debride the tissue injury sites. And they also present antigens on the cell surfaces and secrete cytokines which help in the process of bone healing. Lymphocytes, they also produce cytokines and it's said to be to perform an inhibitory function. So progenitor cells, they come from the periosteum mostly and the endosteum. They differentiate into either your osteoblast or chondrocytes. In other textbooks, they are termed as pluripotent cells as well. So they provide supply of osteoblasts, and also the periosteum as well is the primary source of your chondrocytes. And as we mentioned, disruption of the periosteum leads to failures of healing through invasion of the fibrous tissue and loss of fracture hematoma contents in the surroundings of tissues. So as you recall, the periosteum acts as a protective layer, so it helps contains all the cells within the injury site. Chondrocytes, osteoblasts, and osteocytes. The chondrocytes would produce your extracellular matrix, such as your proteoglycans and collagen. And later, this hypertrophied chondrocytes would participate in your endochondral ossification. If you can recall, is also known as your secondary bone healing. Osteoblasts, by the name itself, blasts, they form bone matrix and regulate the process of bone turnover by influencing osteoclast activity. They produce this type 1 collagen, osteocalcin, and other matrix proteins. They also express alkaline phosphatase, which is one of the markers we use for uh, bone healing, and remodeling. Osteoclasts are also found in bone healing. They're basically responsible for resorption of bone, enabling the remodeling of fractures. They come from the macrophage monocyte lineage, and they have intracellular lysosomal vesicles and mitochondria that dot the cytoplasm of the osteoclast. So osteoclasts basically, the osteoblasts, they form a somewhat relationship in terms of forming bone and in resorption of bone during bone healing and remodeling. The muscle cells, they express markers of bone formation in vitro and in vivo, and it is noted that early soft tissue coverage of severe open tibia fractures can lead to a faster union. So in a way, these muscle cells, they act to cover this bone in order for bone formation to hasten. And cells also involved are your mesenchymal stem cells. I'm sure you're all familiar with stem cells by now. And these mesenchymal stem cells, they supply a cell population that could differentiate either into chondrocytes or osteoblasts based on the stimuli in the environment. And it's important to note that there's a study that claims benefit of injected mesenchymal stem cells in stimulation of fracture repair. Probably by the time we're already specialists, uh, this mesenchymal stem cells would be more and more common to medical practice. So another factor in bone healing is the scaffold. So basically, when we say scaffold, we picture this when we put up a building. We try to build a building. We use a scaffold before we to put up the posts and before we put up the foundations of the building. So basically, it's a three-dimensional process that requires a scaffold to allow cellular components of the healing. So the scaffold, or in some textbook, it's called your extracellular matrix, is responsible for conferring the structural properties of bone and cartilage. It's primarily composed of inorganic material. So inorganic material basically contains calcium, phosphate, and other ions such as sodium, magnesium, and carbonate. The organic portion of bone consists primarily of type 1 collagen and also other types of collagen. So, but the primary type of collagen is type 1 collagen, and you have your non-collagenous proteins as well. So, the semi-solid blood clot in the fracture site that provides the initial scaffold for inflammatory cell migration. So, this scaffold would help provide the structural stability later on. So, another factor in bone healing is blood supply. So, the central role of vasculature, as we see in this picture, you can see a lot of blood supply either coming from your periosteal vessels, you have your epiphyseal and metaphyseal vessels, as well as your nutrient arteries. So when bone is fractured, local blood vessels are disrupted, creating a vascular and hypoxic area. So this hypoxia uh, promotes the production of vascular endothelial growth factors, promoting revascularization. So the absence of competent blood vessels crossing the fracture sites would be your stimulus for angiogenesis. And if you can recall your basic subjects on how revascularization happens in inflammation, it's basically the same. But one particular thing with bone healing, if you can imagine this bone, as I mentioned, there are different supplies. So there's, for example, the fractures here, the the vast vascular supply would in turn stimulate bone healing and revascularization in this site. So you have the other blood supply would supplement the blood supply that's been lost in the fracture site. So the molecules, there are a lot of molecules involved. By molecules, we also mean the cytokines involved in the bone healing. And it's actually an intricate communication system that regulates the actions of the particular cells that we already mentioned. The cellular interactions are primarily mediated through the actions of molecules termed cytokines to receptors on the cell surfaces. So these are some of the molecules that are important in bone healing. You can screenshot this particular slide. So the molecules are the BMP2, the Rankel, the IGF-1. We already mentioned some of these platelet-derived growth factors, transforming growth factor beta. So they basically stimulate the differentiation of the cells. They stimulate the proliferation into either osteoblasts, and they also some would help in the angiogenesis. So types of bone healing, we already mentioned some this in passing in the past lecture. You have endochondral and intramembranous. So endochondral, during development, where we have cartilaginous anlage, is replaced by bone. Okay, so the key term here is the cartilage is replaced by bone. So the process typically occurs as the resident chondrocytes. They're the first to go to your fracture site, and then they mature. Then they later on the vessels will be invaded, and in this way your bone healing and bone formation and the process of skeletal development is almost the same. So in unstable fractures, the cartilage is found in the early phase of fracture healing. And as mentioned, the chondrocytes, they would hypertrophy and then later on be replaced by osteoblasts as the vessels invade the cartilage callus. So the other term for endochondral ossification is secondary bone healing, which basically proceeds to three sequential phases. You have your soft callus, your hard callus, and your modeling. Basically, this healing is associated with movement at the fracture site. So if you can imagine, if there's some gap in the fracture, the most prominent type of bone healing would be your endochondral bone healing. So intramembranous or direct bone formation without a cartilaginous intermediate is called intramembranous ossification, or in other terms, primary bone healing. So basically, there's direct deposition of osteoid by cells of mesenchymal origin. So in endochondral, it's cartilage that goes first. Intramembranous, it's already your bone cells that go to the fracture site for fracture repair. So if one particular point of confusion is that some state that bone healing is primarily endochondral. Yes, in a way, but when in some types of fracture, you want the intramembranous type of bone healing. And intramembranous ossification basically is seen in those without a fracture gap. So fragments, they're united because there's no gap. The fragments are united by passage of osteoclast lead. You have this structure called your cutting cones. So as I said, these two forms of bone healing would represent distinct processes. Modern fracture fixation techniques would benefit from both types. So it's a misnomer to say that one type is better than the other, and neither form of bone repair can be regarded as inferior, with most fracture healing through a combination of these two types. So, as in addition, the time eventually required to restore the mechanical integrity of bones is not reduced by healing either through endochondral or intramembranous. But it's important to note that the influence of mechanical factors on fracture healing would dictate if what type of bone healing would occur, which will be discussed later. So it's, as I mentioned, stages of endochondral fracture repair. So it's a cascade of events that aims to restore the mechanical integrity. So the four stages, we have your inflammation, your soft callus, hard callus, and remodeling. It's important to note that it's not a clear sequence. There's quite an overlap. So when hematoma happens, that's when the inflammation already starts. And at almost the peak of your inflammation, the there's already start of sorry at the almost the peak of inflammation, the soft callus is already forming, and this overlaps with your hard callus formation. So this is a diagram. So hematoma formation, then you have your callus formation, you have your, as I mentioned, angiogenesis, your callus, the soft callus. Then later on, this would be replaced by a bony callus. Later, at this point, there's some healing already. Some Then what happens? The bone remodeling is a continuous phase that happens even for months after the fracture is healed. So the first consequence of fracture is a local structural disruption of bone and marrow, and it leads to accumulation of fracture hematoma. So I, I'm sure you're already quite familiar with what happens during this phase. There's a recruitment of your the cells that are involved in bone healing by your cytokines, and primarily it's the lack of a vascular supply and oxygenation that stimulates your formation of the new vessels. So after hematoma formation, which is your scaffold, the soft callus phase, where this typically begins at the end of the first week and typically by 3 weeks in humans. So depending on the mechanical environment, the cartilage or osteoid becomes the predominant tissue in the callus. So at this point, type 1 and type 2 collagen are produced to form extracellular matrix that restores stability to the bone ends. And at the end of 2 to 3 weeks, you'll probably see some changes already in the radiographs. So hard callus, basically it's conversion of your cartilage to your terminal chondrocytes, then to your osteocytes. So basically it's a wave of calcification where the hypertrophic chondrocytes they they ossify, and then the blood vessels they start to invade the callus. So the dominant cells during the hard callus phase are the osteoblasts and osteoclasts. At this point, you should be able to see some this should be already be visible on your x-rays. because the woven bone that are deposited this time would further strengthen the callus and could already be seen on X-ray. Remodeling, already mentioned some part. You have your cutting cones. Basically, this is the phase of bone healing that returns the previously damaged tissue to its pre-injured state. So what happens is that during remodeling, the canalicular architecture is reestablished and the aversion system with its osteocytes is restored. This starts in concert with your bone consolidation and continues for months or even years after a solid osseous union has been achieved. So, as I said, during remodeling, there's intricate communication between your osteoblast and your osteoclast, which lead to a creation of your lamellar bone. So, previously it has been woven bone, so they start to be more structured, more organized into lamellar bone, and depending on the mechanical stress that has been imposed on the bone. So, at this point, it is important that the bone or the fracture, the healing bone, be subjected already to weight bearing. This phenomenon is, as described by Wolff's law, involves strengthening of the internal and cortical architecture of bones in response to applied loads. It also explains why in astronauts, where there's weightlessness, the bones are not as strong as compared to those subjected to gravity. It's because of Wolff's law. So mechanical influences on bone healing. So as I said, fracture stability influences bone healing. So there's experimental evidence that the mechanical environment plays a role in determining the cellular events that define bone repair. And it is said that mechanical instability at the fracture site favors endochondral ossification. So if the how do you translate this in terms of clinical? So if you have a fracture and when there's two ends that are constantly moving, they would be subjected to your mechanical stresses and therefore some mechanical instability at this point. They would favor endochondral ossification. So some x-rays you would see a very massive soft callus formation. But if this callus formation, this mechanical instability continues, then uh, it could lead to some delay in the healing. So it is important that even if you're not going to orthopedics, it's important that as doctors you understand that when we heal fractures, there needs to be some mechanical stability in order to promote the bone healing. The steps we already mentioned. So we mentioned atrophic non-union. So malnutrition can lead to deficiencies in your cofactors needed in the reactions. So one particular thing we tell our patients is uh, if they're smokers is to stop smoking because it has been said that smokers the fracture healing has been delayed in cholinergic and anti-inflammatory pathways and inhibition of the TNF-alpha. Corticosteroids are said to inhibit the osteogenic differentiation of your stem cells, your osteoblast, and your osteocyte. And so that's atrophic non-union. Hypertrophic non-union, as you can see, is basically the lack of adequate stability. So the problem with hypertrophic non-union usually is it's an unstable fracture. So what happens is the body compensates by uh, putting so much stuff into the fracture site. So, but as we said, the motion of the fracture site, they favor the the progenitor cells. They, instead of turning into osteocytes, they become chondrocytes, and they, because of the constant motion, it somewhat tricks the body that it's it's not a bone that is properly healing. So when you see hypertrophic non-union, basically just need some sort of stability for it to happen. It's also important to note that there's also what we call an oligotropic non-union. So as you can see, the sometimes it's called the horse hooves as compared to an elephant hoof. So oligotropic by the term itself, oligo, so there's some lack of the callus in the area. It's also important to note that there are systemic pharmacologic treatments that influence bone healing. One particular is your biphosphonates. That's a class of drugs that's used to decrease the risk of fracture in patients with low mineral density. So basically, biphosphonates, we use this in osteoporosis. So in some in some patients, biphosphonate use could actually lead in some delay in bone healing. That's why we delay giving biphosphonates to patients who are post-surgery. Another pharmacology treatment is your parathyroid hormone, which is an endogenously occurring regulator of your calcium, phosphate, and vitamin D homeostasis. And and one particular drug is the teriparatide, and it is the mechanism. There's said to be a mechanism of improved fracture healing with your parathyroid hormone treatment in relation to more. They found out that there's more osteoprogenitor cells in the early fracture callus. So it is said to be a stimulatory effect on bone healing. So this is part two of our review of the musculoskeletal system. So we have discussed the skeletal muscle, tendons, joints, ligaments, bursa, synovial sheath, bone, cartilage, and bone healing. This is the post test.